we're framing this project as a public health intervention and not necessarily strictly a research project, and that's for a variety of sort of very good reasons, especially in light of doing research within the Indigenous communities. So I'm going to be presenting most of the background here today. Michelle, who's our project manager for this particular project, is going to be updating us on some of the next steps that the project is currently launching around. We were hoping to get our lead patient partner to co-present with us today. She's unfortunately in Whitehorse. Well, not unfortunately Whitehorse. She's in Whitehorse right now, and she was intending to sort of tape a presentation to sort of be complementary to what we're going to report on today. She was unable to do that, but she will do one at a later time. It'll be available on the web for those to view that later. She has a very good message and a very nice perspective on this project. I just wanted to highlight this slide to start. There's so many partners involved. This is, again, I've been told by the project core team at CanSol, this is the most complex project in terms of the number of partnerships we have to manage. This slide doesn't allude to even the further number of funders that are available for this project, and part of the reason why this project may have been a little bit slower to launch than others is simply because there's so many key stakeholders and important partners from a funding and from operations and planning perspectives. So again, we're coordinating this project right now across Alberta, British Columbia, and Manitoba. Again, at the center of the slide here, we have the Chronic Disease Innovation Center here in Manitoba that will be doing most of the science and data analysis and operations on one side. We also have key partners from the First Nations Health and Social Services Secretary of Manitoba, led by Dr. Barry Lavallee, Carolyn Chartrand, Lorraine McLeod, who are Indigenous healthcare practitioners and scholars that will be sort of shepherding some of the cultural safety as well as operations in terms of screening, triage and treat on the ground within communities in Manitoba and helping to train other provinces. And then again, and of course, we have many other partners that are too numerous to mention right now that we certainly thank for their input in this project, not least of all is the core team at CanSol. So what I wanted to discuss today is number one, creating the burning platform, why we need to do this particular type of intervention, why traditional primary care systems that we have in terms of Western medicine are not sufficient to deal with the burden of CKD, hypertension, diabetes in Indigenous communities, especially in more remote communities. We'll provide some of the evidence for a new paradigm in case finding within Indigenous communities and some of the nuances of Indigenous health that we try to tackle with this project. We will show you some of the findings from the finished project we did in Manitoba. I won't call it a pilot. We did do this similar process to this in over 2,000 people within Manitoba and another close to 700 now in the city of Winnipeg. But again, we're trying to scale this initiative and see how the core elements of it are translatable to other provinces, jurisdictions, other unique Indigenous cultures that may see things a little bit differently than Manitoba. So for that reason, this is extremely important a project from a generalizability and scalability perspective. And then Michelle will again update you a few slides on where we are in terms of project status and next steps as we launch up in terms of actually conducting screen triage treat events across 3 provinces to start. This is just a slide to sort of frame the problem. Manitoba is a bit unique in terms of our population. We have about 1.3 million people in the province, so a relatively small number of people. But 15% of Manitoba is First Nations. We have a significant public health emergency, I'll call it, in terms of kidney failure in this province. So whereas some places within Canada have relatively flat prevalence rates of kidney failure and stage kidney disease, we have several projections that we've done using fairly advanced models, which show that our dialysis prevalence is going to double within the next 10 years. Manitoba, because of our young, large Indigenous population that seems to have a higher prevalence of kidney failure, patients tend to live longer on dialysis, tend not to get transplanted as often for a variety of reasons, and that's so they're surviving longer on dialysis, and that's leading to these really staggering prevalence rates. So to put this into context, our Manitoba Renal Program budget right now is $80 million. Within the next 10 years, we're looking at probably an increase to $200 million a year for operation funding, as well as having to spend capital infrastructure on dialysis units in the tune of $150 to $200 million, which again, to take care of relatively few patients, is not necessarily extracting the value for money for the healthcare systems that we want, but more importantly, the significant morbidity and mortality associated with kidney failure for patients is staggering, and really why we're all in this to improve the health and lives of people with kidney disease. Some of the scope of the problem here we published on previously is this just shows that our prevalence rates of kidney failure in Manitoba are relatively flat in the southern part of the province, which tend to be more urban, tend to have better access to primary care and specialty care services. But in our remote rural north, that part of the province that really is sparsely populated with many Indigenous communities, we see a real staggering increase in kidney failure. Stated a different way, this is a heat map GIS map of sort of kidney failure prevalence in Manitoba, and one can see there, if we look at the dark red colors, which is the higher prevalence rate, up to a 17-fold increase in kidney failure in certain very remote parts of the province. The green circles you see here are areas where we have satellite hemodialysis units. Several of these units are only accessible by air. They have ice roads for a couple of months of the year to get supplies to the communities. But for example, in this area that's extremely high prevalence, Island Lake Tribal Council, which represents 4 communities, there is a dialysis unit there, but during freeze-up and thaw times, which is about 6 months of the year in some cases, we actually have to helicopter people to and from hemodialysis 3 times a week to service that unit. So that unit has an operating budget of about $275,000 per patient per year. And again, this is one of the highest prevalence, highest growth rates of kidney failure probably seen anywhere in the Western world. This just highlights this, a costing study we did. Not it's all about cost, but that's certainly a consideration in delivering value for money anywhere. We can see a couple of our units here are in excess of $200,000 per patient per year, as compared to, say, a facility unit in the city, which is more in line with what the other literature shows of $50,000 to $60,000 per patient per year. So to deliver the same service in these remote communities is, again, sometimes 5, 6, 7, 8 times the cost as it is in sort of an urban unit we're more used to delivering hemodialysis in. So I just want to take this back from kidney failure down to a couple of case scenarios. So that's me there on the left. I'm a 41-year-old physician from Winnipeg. I work at a hospital that actually has 2 family medical clinics in it. I go to a new general practitioner this year because my wife made me, because I turned 41. And I just went to went in and say hi, and I needed some basic prescription cream. And he also said, hey, well, you're 41 now. He screened me for hypertension, type 2 diabetes, and did a lipid panel. Rest assured, everyone on the call, I'm fine. But it just gives me an example of opportunistic screening. So a male who has good access to primary care, excellent access to primary care, goes in. There's not really good evidence that I should go in every year for history and physical and get a bunch of blood work done, but this is an example of opportunistic screening where I was in anyway for something else, and I got screened for some of these conditions. I want to highlight the similar example of a patient that we have in our system who's also 41 years old, but he's from Wasagamak First Nation, which is in the Island Lake Tribal Council, only accessible by air. He's a seemingly healthy guy. He's a school teacher at the local school. He's got a strong family history of patients with diabetes, family members on dialysis. There's a GP that flies in there once a month from what we call the fly-in doctors Northern Medical Unit. It seems to be a different person every month. There's a long wait to see that person when they're there. He really doesn't really have a reason to go to the doctor, but even if he did decide he wanted to go for something, it's really challenging for him to get in. So is his opportunity for screening for chronic conditions at some point different than mine? And that's a sort of an extreme example, but this goes on really every day in many of these communities. So to capitulate things a little bit, chronic kidney disease is common, about 10 to 12% of the population in most Western jurisdictions that have been mass screened. It can be harmful. It's associated with poor outcomes, but certainly in many cases it is preventable. At least we can prevent progression and complications. Most patients, the vast majority of patients with CKD will never need dialysis, they'll never reach kidney failure, but we need a way to treat high-risk patients aggressively and reassure low-risk patients that we should be monitoring them, but be cautious with how much intervention and treatment we give them. A lot of these factors depend on the geography of the jurisdiction, the geography of the primary care system, the local epidemiology, which I alluded to earlier, and then certainly the process of how we screen for disease, because there can be a lot of different ways we do screen and triage disease. So we had the hypothesis in Manitoba a few years ago that our rates of kidney failure in Indigenous patients, or in First Nations patients specifically, were so high that it may be cost effective to deliver care in a different way. We really wanted to deliver preventative care in a different way. So we did a cost effectiveness systematic review of primary screening, meaning sort of mass screening without risk factors of our previous symptoms of chronic kidney disease. And we really found, as one would expect, although it's not obvious to some, that if patients have a history of hypertension or diabetes, or even a strong family history of chronic kidney disease, it tended to be quite cost-effective to screen people on a sort of a universal screening platform. But just going out and screening the general population, for example, if I went to just the local shopping mall in any one of our cities and just set up a booth and started screening people that were easy to access, it would represent actually very poor value for money. So we generated a lot of additional tests and created a lot of anxiety and really not necessarily benefit the system in a good value for money type of way, not necessarily benefit patients. So that's one example of how we look, or where we look for disease, but how we look for disease and how we actually don't generate a bunch of unnecessary anxiety in testing some of it stems out of an evolving science of risk prediction, the science of providing a precise estimate of risk for an individual person. Typically uses a number of factors, and can be demographic factors, it can be biomarker factors like blood tests, urine tests, blood pressures, but those factors in combination can be used to make treatment decisions and help inform communications between providers, from providers to patients, and really tell the story in a different way. And again, with this mantra that we really want to be treating high-risk patients aggressively and low-risk patients a little bit more cautiously. So the science of this has evolved over time. There has been a number of investigators across Canada, including Dr. Tangri, who's the lead author on this publication, works at our center here in Manitoba, that developed this risk equation for kidney failure. So basically using really now 4 main factors: age, sex, GFR, that's your percentage of kidney function, and the amount of protein in your urine. We can feed those factors into an algorithm on a tablet or any portable device or computer device, and it will calculate a 2- and 5-year risk for an individual of kidney failure. And so it's easily accessible parameters: age, sex, GFR, and amount of protein in the urine. And we can feed this into the tablet, and it gives us a meaningful sort of risk of a person's kidney failure. We combine that with work that's been done by our partners here in Manitoba, the Diabetes Integration Project that I mentioned earlier, that actually executes a lot of the on-the-ground screening, and they had a lot of experience previously with point-of-care testing. So it's not feasible in a very remote, isolated community with a small number of people to draw blood, ship it to a mega lab, a big lab in a city far away, and then come back with the results a week or 2 later. People want to show up to screening events, and they want sort of answers relatively quickly. And this is where we've been really successful in using point-of-care testing equipment. So on the blue machine you see on the top right is the Piccolo, which we used during the Manitoba's Finish project. This can do a full electrolytes panel, lipid panels, and so on. This machine on the bottom right is a DCA Vantage. It can do a hemoglobin A1C, which is a test for diabetes or diabetic control. It can also test the amount of protein in someone's urine. This is the machine we're evolving to, which is called a stat sensor, which looks like a glucose testing machine. It can actually, within 30 seconds, get a reasonably accurate estimated GFR, which your percentage of kidney function is. So again, we're probably moving in this test now to phasing out the Piccolo analyzer, using the stat sensor, which again, 30 seconds you get a kidney function, and the DCA Vantage within about 5 to 10 minutes, we can get a hemoglobin A1C or test for diabetes, in addition to the amount of protein in the urine. We're in the process of creating a customized iPad app for both adults and children that Michelle will update us on, that can actually calculate a risk of kidney failure, but also based on other parameters, have algorithms in the background that actually give nurses at the point of care a fairly robust answer in terms of where this patient should be going, and we can actually do relatively high-put screening, triaging, and recommending treatment pathways to patients in a total time frame of about 20 to 30 minutes. So again, the screening takes place with the point-of-care testing equipment. We plug it into our iPad app, and we stream people, and this is color-coded even on the app, into patients maybe having no current risk, normal blood pressures, normal percentage of kidney function, no significant protein in the urine, no known diabetes or normal hemoglobin A1C, and we can certainly do lifestyle counseling with people and things like diet and exercise, but we're not going to necessarily raise any alarm bells for referrals at this point. And then people can be screened in either low, intermediate, or high risk based on a number of factors from blood pressure, diabetes, kidney failure risk, et cetera. And we also make space within this program for not only referral to Western medicine platforms, but also discussion about is there a local traditional medicine or healer in terms of traditional medicines or diet that we should be talking to in that community to sort of liaise with people within that community that would be complementary to our Western medicine platforms. So really you can see this develops into a risk-based teams approach. Low-risk patients, we actually send a letter directly to the primary care providers focusing on things like lifestyle, blood pressure control, et cetera. Medium risk patients all get referrals to nephrologists. These are referrals that we already want to see, and focusing on sort of specific, more specific medications or diets or things like that that can alter the trajectory of chronic kidney disease. And then very high-risk patients we would be putting into most academic centers in Canada, and non-academic centers have multidisciplinary kidney health clinics where people are seen by a complement of a multidisciplinary team, nurses, dietitian, pharmacists, social workers, for that wraparound holistic care of people with that higher risk of progression that kind of need more, a little bit more attention. But we can see here very transparently, resource allocation from the health system are aligned with your level of risk. So again, one thing we've stressed within the finished project and within this project is that we're not going in and just screening, we're triaging, and every single person has a treatment plan, and we actually do audits on all the patients being tested that we do follow through in all of those plans. So no one's kind of left out of the system unless they certainly consciously opt out to further follow up. So again, as I suggested, we did this in over 2,000 people in Manitoba. I just want to give some insight into the results that we got here. This is what's known as a heat map. This is the Kidney Dialysis Improving Global Outcomes Guidelines Clearinghouse has suggested that this should be the way we stage chronic kidney disease. There's two axes here. One is GFR, or percentage of kidney function, on the vertical axis here, and then one is how much protein in your urine, so that urinary albumin-creatinine ratio. So higher protein equals higher risk. So it's kind of a combination of what your percentage of kidney function is and what your protein is. And again, the worst is to have low kidney function and high protein, and that's why those are outlined in red. We sort of capture a lot of this within our risk equation, but this is just sort of translating this to a general population based out of large screening studies in the U.S., what the risk is of categories, relative risk in certain categories in Manitoba's Indigenous population. So one can see, for example, here, people, as compared to a general U.S. population, so Manitoba's Indigenous population had over an 8-fold increase in risk in those very proteinuric patients with normal kidney function. And if we get to the extremely high-risk people, it's a 3- to 4-fold increased risk of those patients in Manitoba. Some will look at this as it is quite a staggering finding. I'll look at it as somewhat of a positive finding, in the sense that the people we can have the greatest impact on in terms of diet, exercise, blood pressure control, blood glucose control, are people that have a lot of protein in the urine. So if you have a lot of old people with low kidney function and not much protein, there's not, unfortunately, a lot of targets that we can do to improve outcomes. But young people with lots of protein, there's lots we can do from a healthcare system perspective to reduce their risk and reduce their trajectory of progression to kidney failure. So that's kind of a positive finding in that sense. We did overall in Manitoba find about 25 to 30% of people in Manitoba's Indigenous population had some form of chronic kidney disease, as defined as persistent protein in the urine or low percentage of kidney function. So what we decided to do to evaluate this further in a subsequent publication this year is we actually did a full cost-effectiveness analysis on this. So we looked at costs of screening, we looked at how many new patients we picked up that we didn't know about before, and then we assumed sort of half of them would go on some sort of disease-modifying treatment. In this case, it was something called an ACE inhibitor, an ARB medication. And we actually ran a lot of simulation scenarios sort of complex mathematical models to look at if this was quite cost effective or not. And what we found is for all of our communities combined, we had about a $23,000 quality adjusted life year incremental cost to this. So it would cost that much per improvement of a good quality of life for patients. And to turn that into sort of more accessible language, new healthcare interventions in sort of a Canadian context would be funded at a level of somewhere between $50,000 to $100,000 per quality adjusted life year. So in any sort of rational evaluation of new healthcare interventions, this would represent excellent value for money and excellent cost effectiveness, even though we were serving extremely remote fly-in communities that are very expensive to screen. It's still better than the alternative of providing expensive dialysis, and certainly better for health and quality of life of patients. And that's really, really important as we're trying to evaluate new interventions. I'm going to hand things over to Michelle now for a few slides before we take questions, just to update us on the existing project and all the activities going on to date.
Okay. So as Paul kind of mentioned earlier when he talked about the point-of-care testing equipment, we have replaced one of the equipment called the Piccolo with something called the STAT sensor for some of the testing. So what's nice about the STAT sensor is that it's a handheld device, and compared to the Piccolo, as you can imagine, traveling with 600 pounds of equipment up to remote communities isn't always the best thing. The STAT sensor is a lot smaller, it's a lot lighter for transport, it's a lot quicker. So whereas the Piccolo might take anywhere from 10 to 15 minutes to analyze some of the samples, the STAT sensor can produce a single result within 30 seconds. In addition, it also requires less sampling for testing as well. So we have partnered with a local community healthcare center in Winnipeg called Access Northwest, which has taken the original Finnish screening model and is screening for chronic kidney disease in urban low-income areas in Winnipeg. So they were the first to pilot the STAT sensor because they have been screening both adults and pediatrics this past year. We found with some of the results, the STAT sensor was producing a higher result compared to the gold standard and some of the results we probably would have received with the Piccolo. Well, the good news about this is that all of those biases can be corrected. So right now, the STAT sensor is undergoing another formal evaluation with a company called CQual in BC. CQual is providing and will be providing all of the quality monitoring services for all of our tests, including the STAT sensor and the DCA Advantage, and so we're currently waiting for some of those test results. In terms of Research Ethics Board approval and protocol modifications, we did receive conditional approval from the University of Manitoba Research Ethics Board. We have submitted all of our responses and should be receiving final approval for all of our current consent forms, materials, and protocol. So next steps would be to begin the REB submission in participating provinces, particularly Alberta and BC as well. We are making some further updates to the protocol as well currently. So for example, in consultation with our pediatric nephrologist here within Winnipeg who works in the Finnish study, she has indicated that some of the pediatric referral guidelines and classification for low and high blood pressure, for example, have changed recently. So some of our referral paradigms and clinical pathways, particularly for pediatrics, have changed throughout this year and will change once again before we move forward. And so we're also enhancing the protocol in response to some of the conversations with our partners of adding more information in terms of the equipment, in terms of training, SOPs, and have changed some of the primary and secondary outcomes in consultation with some of our partners as well. So as Paul kind of talked about earlier, we had developed a iPad application during the original Finnish study here in Manitoba. We were planning on hoping to use that same application moving forward for the national initiative. However, with the way that the application was in its current format, wasn't going to be able to support the national initiative across a few of the provinces in Canada. So what we have done is we've partnered with a company called eQual. eQual is a Canadian health technology company that is based in Ontario that specializes in the development of iPad applications for data collection for health research. They have been successful in launching a couple of platforms that monitor patients on peritoneal dialysis at home while they dialyze, for example. So with the new iPad application, we received some wireframes, which I've included in the PowerPoint here. We're currently reviewing some of the functional requirements as well. So the goal with the new iPad application is the user interface is really going to be enhanced. It's going to allow the screening teams, it will essentially walk the screening teams through each and every single step throughout the screening process, from intake and consent to demographics to counseling to the very end, and even referral letters to primary care physicians or nephrology if needed. So it's easy to use. There are a lot of enhanced security features with this iPad application as well. So eQual has the company has gone through a lot of the data and privacy assessments in order to use this application, not just in Ontario, but in other provinces across Canada. It's cloud-based data storage as well, which is going to be a lot easier for data security. And most importantly, for the application, as Paul was talking about earlier, a lot of the risk is based on complex algorithms that are all going to be calculated in the background. So the good thing about the application is that screening teams won't have to do these calculations on their own. So for example, blood pressure calculations will be changing for pediatrics. That will be in the app in the background. Some of the stat sensor application algorithms to correct for any biases in the samples will be in the background. And the kidney failure risk equation will all be automatically populated for the screening teams. So once they enter in all of the information, the application will tell them exactly what risk each patient is at and what the next steps are accordingly. So in terms of patient engagement, we do have identified our patient lead, Kathy Witz, which unfortunately was unable to join the webinar today. Our first hope was to establish provincial patient teams in order to participate in some of the following activities. So number one would be to review the community selection criteria. So it's really important for all of the participating provinces, including Manitoba, to pick communities that differ in terms of geography, size, region, and accessibility. And also important to have very explicit and transparent criteria, because at this point in time, we're unable to screen all of the communities that want to be screened. And so having that feedback from patient council and IPERC as well would be really important moving forward. Next would be the community engagement. So for the original finished study, as part of the community engagement strategy, usually what would happen is members of the project management team, as well as a nephrologist, would travel up to the communities before any screening dates were booked and do a presentation for the community, for the healthcare team, as well as chief and council and community leadership. And so what we thought would be a really good idea is to have patients within each of the participating provinces travel to the communities selected for the CANSOLVE study and to help us engage the community and do a presentation so that patients can share their experiences with kidney disease. Other areas that we're really hoping to get patient involvement is to provide recommendation on all of our communication materials and strategy, and of course to be involved in the knowledge translation at the end of the study as well. So importantly, at the end of this study, all communities will receive a synopsis of what was found within their community, and that knowledge translation back to the community is really important. Furthermore, for community engagement, getting patients involved in some of the advertising for the study within each of the communities would really be a very good area as well. So for example, we have communication strategies with radio announcements, for example, within each of the communities that patients could participate in as well. And lastly, getting some patients also involved on providing recommendations for educational materials and counseling scripts. So as Paul had mentioned, once somebody has screened, there's counseling scripts that go, that all of the nurses and screening teams are trained on to speak with the patient about his or her test results, and making sure, once again, that those counseling scripts are culturally sensitive and appropriate would be really good feedback from patients as well. And so a lot of this information, Kathy will be presenting at the next IPERC meeting, I think, which is next week. So as we move forward, we are currently still updating our standing operating procedures. So we do have about 10 SOPs currently developed that walk through all of the screening process from beginning to end, which we are currently updating as some of the new referral guidelines and pediatric guidelines are being updated as well. Updating some of our educational materials and hopefully collaborating with some of the other CanSolve networks that have educational materials directed towards Indigenous communities. Updating the referral guidelines, community engagement materials, training manuals, especially with the new iPad application, and establishing a local advisory committee. We were also hoping here locally within Manitoba to create a new communication avenue with a separate website and social media to update all participants and patients and training teams. And that's it.
Good. So thanks very much, Michelle, and to all of you for your attention. We were told we should be presenting for about 25 to 30 minutes and leave lots of time for discussion. So, Milan, if you want to triage some of the comments or questions from here, but we're happy to answer any questions.
So, Paul, it's Adira, and Michelle, thanks so much for sharing all the experience and the review with all of us. I think one of the things that we've been hearing, and I wonder, and I know that Kathy Woods and others are vetting some of the materials, but one of the things that in BC came up was that we were trying to make sure this was actually looked at as a kidney health screening initiative, not a kidney disease screening initiative, and that all of the wording on the apps and various other things should be reflective of the more positive as opposed to the more negative. And I was just wondering if you were getting the same feedback from other people, because the app and everything else all talks about kidney disease as opposed to, you know, kidneys are healthy, not so healthy, not very healthy at all, quite unwell, you know, as opposed to moderately diseased, you know, that kind of thing. So I was just wondering if you heard that from others as well, or if that's something unique to BC, and whether there was.
I think that's an excellent point, Adira. That's something that we've heard, I think, within this project and also externally. In fact, our Manitoba website for our renal program, we've been told by a number of avenues we want to not use the word renal, and we want to create a positive spin on things. So we actually are called kidneyhealth.ca as our website domain, and our kidney clinics are called kidney health clinics. So that's something I think within Indigenous and non-Indigenous patients, that positive lens is very, very important. I think we will, you know, certainly we'll note to go through within a fine-tooth comb to kind of make sure that we're reflecting that strong message from patients. One term that we might discuss feedback on is we've really used the term risk, not kidney disease. So we say no current risk, low risk, intermediate risk, or higher risk. Whether that terminology is appropriate or not, or how that makes people feel, because we're not diagnosing people with disease, but you know there is a risk of progression or things like that. That, you know, we do need to raise some sort of a higher level of processing for patients to get them into the clinics that they need for prevention. But I think that language should be all reviewed at all levels of the project by patients to make sure that the people are generally comfortable with it. So it's an excellent point. Thank you.
Thanks.
Hi, it's Gina Gaspard from First Nations Health Authority. I'm wondering if you could give an indication of how many people who were screened and needed to come into a clinic, so leave their community and go to an urban setting, or go to an urban setting to see nephrologists, so moderate risk or high risk, how many actually didn't show up, or if that was an issue at all?
Thanks, Gina. That's an excellent point. So one very strong message we had from our Indigenous partners and patients within the Finnish program, that this is, again, was a public health intervention, not a research project, and it really was very important to a lot of the elders consultation we did as well, that no patient or no person would get kind of left behind or caught in the shuffle. We know there's a variety of challenges within certainly our local, but even more importantly, more remote communities. There's a variety of challenges and reasons why people don't sometimes make it to their appointments. We audited all of our communities many times at different sort of 3, 6, and 12-month intervals to ensure that people were being, if they didn't get to their appointment, people were being contacted, health centers and nursing stations being contacted to sort of give everyone, we didn't want to, again, be pestering people, but give people the opportunity to show up to appointments or to be interviewed via telehealth if it wasn't convenient for them to come down. And I can say that I believe it was either 1 or 2 patients that just, quite frankly, just said, I just don't want to be followed. I don't want to bother going to the city because I have other things going on in my life right now, but they would be happy to be followed in primary care within those communities, and we sort of kept tabs on them. But otherwise, you know, sometimes it wasn't the first time, but we were able to again, see and integrate into our clinics every single other patient at intermediate high risk. To sort of further that question a little bit more, is the low-risk patient, that's always the question, and did they actually get the follow-up in primary care or not? Our plan for following up those particular people is to, you know, follow them through administrative data platforms to see, you know, did they actually get another test done? Did they actually get put on the medication that we would suggest that maybe that would be a good idea for, just to get a sense of how effective those low-risk interventions were in education was. But we won't have data on that for a few years down the line because we're looking at more longer-term outcomes. But yeah, we were pretty, I think, pretty successful in getting those people into our clinics on the most part.
The commitment to make sure that we do as much telehealth consultation, i.e. keeping people in the community for the initial consultation as much as possible, so that we don't unnecessarily inconvenience people, so that might not be a reason to not access the care. Sorry about all the double negatives, but trying.
Yeah, I think what the message we heard, Adira, was that a lot of people just want options, right? For one person, they really want to go see physically their doctor, nurse, and team. Other people, it's very important for them to remain in their communities. Our particular clinic is set up in that I think many clinics in BC are set up that we have one of our actual rooms as a virtual room. So we cycle through our interdisciplinary team through that one room, just like it was another room in our clinic, and it's kind of a seamless integration. We have one city, Thompson, Manitoba, which has several First Nations communities around it, that actually has a CKD nurse there that can actually shepherd and patients through that process as well. But there's a lot, I think the point is that everybody's a little bit different with how they want to seek out care, and we just have to be flexible to that. And it doesn't always mean everybody's got to attend in person. That's just not something that we want to promote.
And I think we just probably in the project will make sure that we capture the different preferences that people have, so that we can understand the various needs.
Yeah, exactly. Yeah.
But on behalf of the CanSolve leadership, Paul, Michelle, and all of the team that's working incredibly hard and long, thank you very much for all the work you're doing. And please, this isn't maybe the end of the conversation, but just that I have to leave. So thanks again, and look forward to updates. And just, Mila might have mentioned this, but this presentation is available on the website afterwards.
Yep. And we will be adding, hopefully adding Kathy Woods' her addition to the presentation as well. Again, apologies that she wasn't today.
All right, thanks. I just want to ask if there's any more questions for Paul.
It's Anita here, Anita Kaczynski in Alberta. Hi, Paul. Thanks very much for the presentation. It was wonderful. I really appreciated that. I wondered if you had received any questions from the communities that you've been working with on this project about, how it's going to be sustained in the long term, or how, some ways that can help them.
Yeah, that's excellent, Anita. As sustainability for these, not sustainably funded projects is always a major concern. Again, I think as with any new delivery model in healthcare, it's going to be a process of getting sustainable funding for these types of initiatives. It's really important to do it in Manitoba at a reasonable scale, I think it was really important to present our findings in academic journals and conferences and perform cost-effectiveness analysis. But at the end of the day, it's one province. We're one very small province. We have a very unique geography here. That's where I think scaling this out to the fact that CanSolve and the patients were interested in this particular project to give it attention and actually funding is a testament to not only sustainable in Manitoba, but sustainable across Western Canada. I can tell you we've also had interest from and discussions with Indigenous scholars in New Zealand and Australia, in addition to even other populations in Northern and Southern California with some of their Hispanic populations and more, I guess, areas that have high burden of chronic kidney disease and dialysis with the researchers at UCSF and so on. So we're already garnering both national and international attention for this. And I think that's the only way it will receive sustainable funding down the road. And I think the more momentum we get, which we seem to be getting, is the more likely it's going to be received well by government payers. You know, I'll give you an example. In Manitoba, we have a dialysis unit that was built about 5 years ago for $5 million that basically has 2 patients dialyzing in it. And if I actually go within those communities and say, you know, we probably could have, you know, done this process in most of Manitoba's First Nations communities for that price of that 1 unit, the overall utility, there might be a better way or better way of spending that money that's allocated to kidney patients that receives a lot more utility for Indigenous patients. So I think that's making that case to Health Canada, to provincial funders, but I think that the fact that this project's funded and we're having so much international attention now on this type of process is a testament to the sustainability will likely come.
Thanks, Paul. That's great.
Hi, Anita. It's Neela here, and over here in BC, as we're having meetings with Gina at First Nations Health and Evan Adams, we're realizing too on the value of this project. Like right now, we don't have funding to screen all the communities in BC, but just a subset. But even screening that and capturing the value and approach to sustainability of this program, taking that and presenting it to the Ministry of Health and the different funding agencies where there's potential to get more funding and garner more momentum to get this program into the different other communities. But first we have to demonstrate that there's value and it's sustainable for that to happen.
Exactly. Yeah. Thanks, Neela.
So if there's no other questions, maybe we want to thank you again, Paul, for presenting, and thanks everyone for making the time.
Thanks, Neela and the team and everyone for attending.
Thank you.
Email us anytime with any other questions.
Thank you.